So we are starting in three, two, one. Please start, ma'am. We are live.
So we'll wait for 1 minute and then after we'll start. Very good evening, ladies and gentlemen, and a very warm welcome to Secrets of Neurology, Knowledge Feast for all neurologists. We are delighted to have you with us for episode 62, hosted in collaboration with Dinanath Mangeshkar Hospital, Pune, where today's theme is Diagnostic and Management Enigmas. At the heart of this academic journey are our visionary course directors, two stalwarts who have shaped neurology in India and beyond. It is my honor to introduce our course directors, Padma Shri Dr. Sudhir V. Shah sir, a name synonymous with excellence in neurology. Professor and Head of Neurology at Srimati NHL MMC and SVPMISR Ahmedabad and Director of Neurosciences at Sterling Hospital. He has been honored with the highest recognitions in medicine, the Padma Shri Award, the Dr. B.C. Roy Award, and international fellowships such as FRCP from London and FAN from USA. Author of 6 books and countless scientific publications. Sudhir Sir's pioneering work in neurology has been featured globally, including on BBC and Discovery Channel. His contribution to stroke, epilepsy, and neurodegenerative disorders continue to inspire generations of clinicians and researchers. It will be honor also to share that he has been awarded with Bharat Gaurav Award at Senate of France on 5th June 2024, one of the highest international awards for Indians. Our second pillar of Secrets of Neurology and our course director, Dr. Lakshmi Narasimhan sir, a teacher, leader, and global voice for neurology. He is a professor and head of Department of Neurology at Sri Ramchandra Institute of Higher Education and Research, Chennai. Honored with the A.B. Baker Award and Global Best Teacher by the American Academy of Neurology and the Elsevier Global Atlas Award. Dr. Lakshmi sir has been an executive leader in the World Federation of Neurology and has mentored countless young neurologists through the celebrated SHINE programs across India. His passion for teaching and advancing clinical neurosciences has made him one of the most respected academic neurologists in country. With such esteemed leaders guiding us, today's session promise to be both insightful and enriching. We also extend our gratitude to our distinguished faculty from Dinanath Mangeshkar Hospital who will be presenting the leading today's academic feast. With this, I hand over the session to our course directors to take it forward. Sudhi sir, over to you.
Thank you, Shweta. Thank you for your very kind words. This much elaborate introduction is, I don't think, is necessary. Anyway, so today, before we start, I'm here to tell you that this is our 62nd episode of this Secrets of Neurology Knowledge Feast of All Neurologists webinar series, and that's itself a record. The high spirit of the science that this series contains, the, the consistency, the type of cases they are being presented here, and the institution that they have joined here are some remarkable things for this season. That is why till now for 62 months every month, last Friday or Saturday, we hold this. So there is a lot of interest from all the delegates. So I must thank all the delegates heartfully, and also thank all the institutions, all the HODs, and all residents and assistant professors who have contributed immensely to the success of this program. And to add to the list, we have today Dr. Shripad Pujari, the lead neurologist from Department of Neurology, Dinanath Mangeshkar Hospital, Pune, who is his team is presenting 2 cases of diagnostic and management enigmas. So may I have the first slide, please? I must also thank enough the Celestial Division, that is a Global Cell Division of INTAS, for supporting this scientific work with the networking and all lot of logistics. So thank you, Mr. Chadda and the team. And I must also acknowledge that there are a lot of people coming, joining from distant places other than India, from the surrounding and distant countries, including sometimes from Canada, USA, and Spain, France, and nearby countries. So I really thank all of you. Today, my co-course director, Ms. Dr. Lakshmi, has some emergency work. So he has not joined now. Maybe he will join within some time. But if I don't thank him enough, I would be, considered a man without proper permission. And then Dr. Lakshmi has done a very, very hard work to support this program and to take it forward. So thanks, Dr. Lakshmi. So Gargi Pore, Dr. Gargi Pore, Senior Resident Department of Neurology, Dinanath Mangeshkar Hospital, Pune, shall present case. So there are 2 cases. So Dr. Gargi is presenting, and second, Dr. Shrijita Sen Gupta, Senior Resident Department, same of Department, Dinanath Mangeshkar Hospital. She is presenting the second case, I believe.
Yes, yes, sir.
There are diagnostic dilemma and the naturally therapeutic problems. So Dr. Shripad would be the right person to take us to the whole journey. And we know that he's one of the most enthusiastic, dynamic neurophysicians from Dinanath Mangeshkar Hospital. He's assistant editor to Annals of IAN, Secretary of Neuro Society of Pune and Maharashtra Association of Neurology Man, and is a DNB teacher and examiner also. He had his neurology training from JJ Hospital, Mumbai, and fellowship and research in London, and he was awarded fellowship in Royal College of Physicians, UK. So he has multiple interests, including rheumatic disorders, MS, NMO, MOG, neuroinfections. He has to studied several book chapters and publications. His faculty at several international and national conferences, and is active in organizing conferences for neurologists, PGs, and physicians. As we all remember, last month he had organized a wonderful conference on neuroinflammation in Pune, along with his team, and is involved in other various patient awareness and education programs. May I have the next slide, if any? Yeah. So without much ado, I would hand over the mic to Dr. Shripad Pujari to take this forward and make this a memorable session as we expect from him. Dr. Pujari, please.
Yes. Gargi, whilst I speak, do you want to start sharing your slide?
Yes, sir, just a
Yes.
moment.
So, good evening, everybody, all my audiences and my esteemed faculty, Professor Sudhir Shah and Professor Narasimhan. I thank both of you and Intas Pharmaceutical to have given me us the opportunity and having organized this session. And the theme today, as you can see on the screen, is there are two cases, and I'm going to address both diagnostic and management issues, and hope you all find it useful. And let us begin our first case, which will be presented by my resident, Dr. Pore. So I request her to begin.
Good evening, everyone. So I'll be taking you all through the first case.
I think Gargi, just click on the screen once and it will go ahead.
Yeah,
Yeah.
sorry. So I'll be presenting a case of a 16-year-old boy who suffered an episode of right-sided hemiparesis with rapid cognitive decline at the age of 12 years, and his weakness progressed over 10 to 12 days before it stabilized. There was no history of any maternal infection, delayed cry, poor suckling reflex, or early seizures in his life, or any myoclonus. He had gained milestones at an appropriate age, and he was a product of non-consanguineous marriage. No other family members were affected. So he was first treated by the pediatrician before coming to us, and the pediatrician had done an MRI when he presented with the above complaints. So on the FLAIR axial sequence, we can see confluent bilateral symmetrical frontoparieto-temporal white matter hyperintensities. And on the T1 axial post-contrast scan, there was not much contrast uptake. And on the right side, the angiogram is shown, which was fairly normal. So the patient was treated by pediatrician with IV methylprednisolone for 500 mg OD for 5 days, and he showed improvement. Going ahead, he had another episode of similar complaints, this time on the left side with cognitive decline at the age of 12 and a half years. And the symptoms were subacute in onset and progressed over 10 days. So this time the MRI was repeated. Here we can see kind of similar picture in which there are bilateral frontoparieto-temporal white matter hyperintensities. And again, on the post-contrast scan, there is not much contrast uptake. So this time also the patient was treated by the pediatrician with IV steroids for 5 days and he improved. So going ahead, at the age of 13 years, he had 2 episodes of generalized tonic-clonic seizures, again treated by the pediatrician with IV levetiracetam. There was aggravation of neurological symptoms like impaired cognition, imbalance whenever he had any viral infection. But he improved overall, so he was able to perform activities of daily living and attended school. Up to 40
Yeah, so
years of
up till this time, the patient was under a pediatrician, and it is only now that Gargi is going to tell that he, for the first time, had a neurologist visit. Gargi, go ahead.
Right. So at the age of 14 years, he first showed a neurologist for the residual symptoms. That was heaviness of legs, and the neurologist found that it was spasticity. At that point of time, his CSF analysis was performed, in which the routine and microscopy was normal, OCB was negative. Also, his arterial lactate was normal, and serum aquaporin 4 and MOG antibody were negative, and ANA blot was negative. So at 14 and a half years of age, he suffered another episode of left-sided hemiparesis, which was subacute in onset. And inquiring further, the parents reported average performance in school exams. On physical examination, the patient's head circumference was normal. He was an alert, cooperative child. There was no deficit in his cranial nerves examination or any frontal release signs. He had spasticity in his legs. Power was 4+, spastic gait, and all deep tendon jerks were 3+, and the plantars were upgoing. His sensory examination was normal, and coordination was within the limits of spasticity. At that time, patient again underwent an MRI brain. So here we can see on T2 axial sequence, there are multiple bilaterally symmetrical fronto-temporoparietal white matter hyperintensities. But this time on the post-contrast scan, we can see that there are bilateral round to discoid contrast uptake in fronto-temporoparietal regions, which was not there previously. So at this time, what could be the differential diagnosis with the given history and the investigations? So the neurologist thought that It could be some form of leukodystrophy, which has episodes of rapid worsening, or it could be a lymphoma since he was responding well to steroids, or could it be a relapsing demyelinating disease? On further workup to rule out other possibilities, the MRI spectroscopy was done, which was not suggestive of any malignancy. His very long chain fatty acid levels were normal, and genetic analysis for leukodystrophies was negative. His serum and CSF lactate was also normal, and CSF routine cytology were not contributory, and OCV was also negative. We even went up to the extent of having a discussion about whether to perform brain biopsy to make the diagnosis, but
No, stop at that. Yeah, you go ahead. Just don't go to the next slide. But you go
right,
ahead.
but the parents were not very keen on doing an intervention unless that was the last step that we could do. So we decided to send other workup in his blood,
Yeah,
such as
just hold on now. Anybody from the audience wants to discuss about this case and give their own insights about this type of a peculiar clinico-radiological presentation and the journey through which our child has been through. Any other thing that anybody wants to suggest on this case, which both in terms of the MRI findings or any further investigations? Shweta, is anybody volunteering? I don't know. Maybe I can't see the list actually. I don't think there is anybody who wants to come up. Okay. So what we have really is a young child who has recurrent episodes. They've all involved recurrent subacute episodes of neurological worsening involving the motor system, subacute rapid worsening in cognition, MRI. There has been flare-ups after viral infections. MRI has always showed relatively symmetrical hyperintensities involving mainly the white matter, and the later MRIs have also showed some contrast enhancement. He's been through an extensive workup, literally, for white matter diseases like leukodystrophies, as you can see on the screen, even for mitochondrial cytopathies, although I must say there has never been a diffusion restriction. He's also underwent certain metabolic workup. His CSF has not been very contributory. We've also went ahead up to a ray of spectroscopy to look for malignancy. The CSF was never contributory, although the cytology was also performed once, and even that was negative. The oligoclonal was negative. So, well, as you can see, even the genetic workup was performed, and even that was negative. We've reached up to a stage where we got, I must say, we got a stage of slight dead end like situation. We couldn't really get across any further. And then, Professor Shah, you want to say something?
I just missed what were the optic nerve findings in terms of fundus, visual acuity, perimetry.
Sir, I don't think he ever suffered any visual symptoms. I don't remember whether he's had a perimetry, but I distinctly remember he had a VP and the VP was normal, sir. VP has been normal. Once it was performed. I don't remember the perimetry, whether perimetry was performed.
All right, okay.
So here we are, a child whose MRI looks MRI has always shown symmetrical white matter lesions. Although I must say in the last MRI there has been some enhancement, and we would expect with that MRI, a gradual progression like a leukodystrophy. However, his episodes have been always in the form of a subacute worsening, either in the motor system or in the cognition.
I know.
So let's go ahead now. Yeah. Yes, sir.
Yeah, I now know it. So I won't speak. Go ahead. I
Yeah.
understand now what you want to say.
Right. So going
Gary,
ahead to
go
the
ahead.
case.
So when we had go to the previous slide for just a second, Gary. So as you can see in the most recent admission with the neurologist, we were going through each and every aspect of workup which we would find relevant for this given presentation. And there was this one point that was lingering in my mind. And remember, although he has these symmetrical things, there was contrast enhancement. And because of that, go ahead, Gargi now.
Yes, sir.
Yeah.
So
Go
we
ahead.
did further workup of the patient, in which, along with the previous workup, we had also sent his serum NMO and MOG levels, which took approximately 5 to 7 days for the results to come. But this time, the MOG antibody had turned out positive.
Correct. Remember that his NMO and MOG antibodies were performed previously by a neurologist, and those were the only point is that those antibodies were at that time performed when this child first visited the neurologist, and at that point of time the child was well. He had visited the neurologist between the relapses when he had no symptoms of an acute relapse, and at that time both his NMO and MOG antibodies were negative, and this was a point that was ticking in our mind. And with that, along with the other blood and MRI and other workups, we had already sent these, and this time we had our MOG antibody come back positive. Gary, go ahead.
Yes, sir. So the patient received a course of IV methylprednisolone, along with after that 2 courses of IV rituximab spaced by 6 months interval. And he has been free of any further relapses or seizures since then, and his scholastic performance has also significantly improved. A repeat MRI was performed after receiving rituximab, in which we can see there is improvement in the white matter hyperintensities bilaterally. Also, the contrast uptake, which was there in frontoparieto-temporal region, has significantly improved, and this is cleared up as compared to the previous scan. So, coming to the important point here, that there is a proposed diagnostic criteria for diagnosis of MOGAD.
Just a second, Gary. So there are two very important points that we as presenters would want to bring up from this case, of which the first point is in relation to clinico-radiological presentations of MOGAD, and this slide pertains to that, and Dr. Gargi is going to take us through that. And the second is about MOG antibody testing itself, and we have few slides on that as well, and just carefully listen to the slides, and we have very important take-home messages from now onwards. Over to Gargi.
Yes, sir. So to make the diagnosis of MOGAD, there's a proposed diagnostic criteria by Banwell et al. Published in 2023, in which there are 6 core clinical demyelinating events, and the patient has to fulfill at least one of those along with others. So the 6 core clinical events are optic neuritis, myelitis, edem, cerebral monofocal or polyfocal deficits, brainstem or cerebellar deficit, and cerebral cortical encephalitis, often with seizures. And
But remember, these, even with NMOSD, we know that there are 6 core characteristics. However, in addition to them, there are few more clinico-radiological features with which NMOSD presents, such as patients can have just press-like lesions, patients can have hypercipikemia, patients may have pruritus, or patient may just have somnolence and things like that. And the ones that I just mentioned for NMOSD, more so aquaporin positive, these are not any of the first 6 core characteristics that are included in the diagnostic criteria of NMOSD. So even with NMOSD, you may have a patient who presents with certain unusual clinical features, and we have to also stay aware of them. I hope you all remember around 1.5 years ago, Dr. Rahul Kulkarni and our team and Dinanath had presented a patient of NMOSD who had presented with multiple clinical features, of which 2 of them were pruritus and hypercpkemia, and those are the ones that are not listed. Like MOGAD is a disease that has been discovered even more recently. The knowledge about it is evolving, and we are yet in the process of crystallizing all its clinico-radiological features and putting together the diagnostic criteria. The most recent ones after the committee met has been displayed for you on the slide. And we just went through the 6 ones, and then now, and we also saw an unusual one in our case, and Dr. Gargi is also going to present a couple of 2 or 3 other unusual ones. And then we are going to have a few slides on mock antibody testing. So Gargi.
Yes, sir. So here we saw in our patient and some other articles as well show that there is an uncommon manifestation of MOGAD in which the patients present like a progressive leukodystrophy like demyelinating syndrome with MOG antibodies, especially in children.
Yeah.
And talking about this phenotype, the patients with relapsing neurological syndromes associated with leukodystrophy like imaging pattern that emerges over time, and they can present with encephalopathy, focal deficits, ataxia, optic neuritis, and or seizures.
Like in our patient had used to always have subacute cognitive decline, like which you could call an encephalopathy, and he used to also have hemiparesis, episodes of hemiparesis. Go ahead.
Yes, sir. They can also have persistent cognitive and behavioral problems, and MRI findings of predominantly confluent bilateral white matter changes raise the suspicion of a leukodystrophy, as we saw in our patient also. Some other uncommon manifestations of MOGAD. So here I'll be talking about a 37-year-old male who presented with seizures and mild right hemiparesis, and his MRI showed left temporoparietal frontal cerebritis, as I've pointed by the highlight pointer, with leptomeningeal enhancement, which is seen in on the right side. And this entity is called as FLAMES. So it stands for flare hyperintense lesion in anti-MOG antibody associated encephalitis with seizures. So this is another uncommon phenotype. And so third uncommon phenotype would be, so in a case of 33-year-old female who presented with seizures, her MRI showed bilateral hemispherical leptomeningeal enhancement, but it is more prominent on the right side as pointed by the arrow. This is called as FUEL, which stands for flare variable unilateral enhancement of the leptomeninges. And there's another fourth uncommon manifestation of MOGAD, which is called as MOGAD and NMDR overlapping syndrome. So there is coexistence of MOG and NMDR antibodies in the same patient, and they can present with atypical NMDR encephalitis or atypical MOGAD. But this entity requires more aggressive treatment than MOGAD alone, along with cancer screening of the patient. So
now the second point.
Right. So why do we keep monitoring the patient? In the seronegative MOG negative patients, MOG antibodies can become negative in between relapses. So conversion,
Like it has happened in our patient. So for the first neurologist who saw this patient, he had actually rightly sent the NMO MOG antibodies, but because they were in between relapse, the MOG antibodies turned out negative. And so he was left without diagnosis, it's big diagnosis. He did see this patient who had recurrent subacute episode with white matter change, and he probably suspected demyelinating disease, but because the MOG was negative, the NMO was negative, and the OCBs were obviously negative because he was MOG, but the OCBs were supposed to be negative. He probably was not able to make up his mind as to what he should do, and so patient was not started on immunotherapy. And then it was during that relapse that we sent it again, and at that time it turned positive, and that is how we could clinch the diagnosis. So it is important to learn about MOG antibody. It's difference. There is a difference between aquaporin 4 antibody and MOG antibody. Aquaporin 4 antibodies can also fluctuate. However, it is extremely rare for aquaporin 4 antibodies once a patient has aquaporin 4 disease and he's antibody positive for these antibodies to become negative. But MOG is a different cup of tea, and we are going to learn what happens to MOG antibodies during the course of illness.
Yes, sir. So seroconversion to MOG IgG negative. While a negative test suggests remission, a transiently negative result does not rule out a future relapse. So that's why there is an importance of testing MOG antibodies for making diagnosis and treatment. So by testing, we also predict the relapse risk. A conversion from positive to a negative antibody status is a significant indicator of having a lower future relapse risk. Similarly, for monitoring the disease course of the patient, a repeated MOG antibody testing can help track the disease. It can potentially identify a reduced risk of relapse. On the other hand, if the risk increases, if the levels of antibodies rise again after being seronegative. So longitudinal MOG IgG seropositivity was found to be associated with a relapsing type of MOGAD.
So remember, there will be different patients having different ways by which the MOG antibody would behave in the blood. There will be some, and as many of you all are well versed with MOGAD to a large extent. The literature describes that many patients are monophasic, and then the MOG antibody stays for some time, and then it goes down. And because it's a monophasic illness, it may not, neither will the patient come back with any symptoms, nor may the MOG antibodies rise again. And then there are those relapsing patients. The percentage has been described very variable, anywhere between 40 to say 75%, they say, could be relapsing. And then there are those in relapsing where in majority of the patients during the relapse, the serum antibody levels would rise. But then in some, the antibodies over time and with use of immunotherapy may go down. Whereas in some, the MOG positivity may remain consistently, moderate titers through their course of illness. What the last bullet says, longitudinal. And if that is so, then that is more suggestive of a relapsing MOGAD. And such points such as these may it's not really a something that has come up as a strong guidelines, but points such as these in MOGAD may help us to decide which patients would require immunotherapy for a longer duration. We would be able to monitor. Unlike, in multiple sclerosis, we still are at a question. What do we do after 5-7 years of immunotherapy, DMTs? Do we stop? What do we do? At least in MOG, maybe in the future, we may have an answer in the form of these ups and downs with the MOG titers, that those who have a persistently moderate titers probably are the ones who may require immunotherapy for a longer time, whereas those as of now the duration is not yet defined, so maybe after 2 or 4 years, consistently if a subset of patients remain MOG antibody negative, we could think of reducing or stopping immunotherapy in that subcategory of MOGAD patients. It's not yet well crystallized as yet, but unlike MS, here the way many neurologists like I see the situation, MOG antibody could be helpful in monitoring the disease and deciding the fate of the treatment, that is the immunotherapy. Go ahead, go ahead.
Yes, sir. So the importance of testing is for diagnosis as well as treatment. So in clinical practice, antibody levels are important, but they must be considered alongside a patient's clinical symptoms. Any new or worsening neurological symptoms are the primary indicator of a relapse and not just the change in antibody levels. So we have to
Absolutely.
correlate both.
Absolutely. Just a minute, just a second. So again, remember, some of you who may have, as Professor Shah mentioned about our CNS inflammatory course, there is a lecture, and there are many articles now floating for uh, false positive, more so in autoimmune encephalitis. So sometimes it may so happen that the clinical syndrome is not matching with a particular autoimmune encephalitis, and the antibody gets sent and it comes positive. At times it could be false positive. So remember, MOG antibody has a very important role in diagnosis, but it has to be associated with clinico-radiological, syndrome, which is matching with the MOG antibody disease. Otherwise, if you just send a random MOG antibody is come positive in a patient who does not have clinical radiological feature, then it probably doesn't carry much of a meaning. Remember that as well. So at times it could be just a false positive thing if you don't send it in a correct scenario. Go ahead.
Then talking about the role of CSF testing for MOG IgG. MOG IgG testing in CSF alone has very low sensitivity on its own. And CSF testing has to be used in selective circumstances only, such as to support the diagnosis in MOG IgG seronegative patients, and only when there are supporting clinical and MRI features suggestive of MOG. So as per the proposed criteria, aquaporin 4 IgG seronegative and more than one supportive clinical or MRI feature, along with exclusion of better diagnosis, including MS, is required for considering CSF MOG IgG positive as significant. So the take-home messages would be MOG antibody can be negative if performed between relapses when the disease is quiescent, as in our case. And there are some uncommon presentations of MOGAD which we saw. Some of them are leukodystrophy like flames, fuel, and MOGAD and NMDR overlapping syndrome.
Fantastic. Well done.
So thank you so much. These are my references. And we'll go to the next case presented by.
I think what we'll do is we'll let Professor Shah. Professor Shah, you want to comment upon the case? Sir?
No, I think it is absolutely brilliant, and you have covered up most of the things, including importance of antibody testing, tracking, diagnosis. I think treatment part, I'm sure, will take later, but this case is an eye-opener that we have to understand that this is a monster with many faces. So one should not be with a fixed mind, and this
Yes.
raises a lot of issues for us, a lot of confusion. So we have to be very careful in treating patients with, particularly white matter disease. But when you have encephalitis also in addition and unusual presentation, so only thing which will help is vigilance and keeping the diagnosis in mind that MOGAD or similar syndromes can have many presentations. Thank you very much for this, and let's have the next
Sir.
one.
Yes.
Excellent. Thank you,
Yeah, Lakshmi.
Shripad.
Dr. Lakshmi, welcome.
Shripad, yeah, I joined it late, but anyhow, I thoroughly enjoyed the later portion of that.
Yes,
The
sir. Good.
test is the flames and the fuel. Are
Yes,
they
sir.
acronyms or just?
Yes, sir. They are the acronyms for.
Could you, for the sake of the
Yes.
students,
Yes, they are
I
acronyms.
joined. Can you expand the acronym?
Yes, Gargi, you want to do
Sir,
it?
I've just displayed on the screen.
Yeah, please, so sure.
Is it visible?
Yeah,
Yes, it
it's
is.
visible.
So
Right.
just read through the
Flames.
long forms.
Flyer, hyperintensive lesion, anti-MOG antibody associated encephalitis.
Encephalitis with seizures. And
Then the
fuel is flare variable unilateral enhancement of the leptomeninges.
Okay, thank you. Thank you. And excellent presentation, and my hearty appreciations to you.
And second consecutive day, I am enjoying you, Shripad.
Thank you, sir. Thank you very
God
much.
bless you. Thank
It's
you.
because of you that I am getting
No,
this
no,
opportunity.
we are all happy. Thank you. Sir, Sudisha sir, good evening, sir. Thank you.
Yes,
Thank
sir. Yeah.
Thank you. Let's go to the next case.
Okay.
Good evening, faculty members and my colleagues. So moving on to the case 2. So we have a 22-year-old male in November 2019 when he was the age of 16. He developed left-sided ataxia and no other clinical features. On the MRI, there was a flare hyperintense signal left in the left cerebellum as well as the MCP. Unfortunately, those films are not available. They were done outside. And as we know that MCP infiltrates are very commonly seen in MOG, the anti-MOG antibody tested positive. We treated this patient with pulse steroids of IV methylprednisolone for 5 days. And after the course, we started him on azathioprine 50 mg BD. So just a quick recap as to the use of azathioprine as a maintenance immunotherapy in MOG patients. So as you can see, this article by Chen et al., they've said that it's a very effective maintenance therapy for MOGAD patients because they've shown that there is a significant reduction in the ARR from 1.6 to 0.2. Okay, so now progressing slowly. In May 2020, while the patient was on azathioprine, he developed a left-sided ataxia once more. So now when you see the MRI images as pointed here, you can see that
Sabji.
okay. So on the MRI, we can see some flare hyperintense and cerebellar enhancement. So you can see the left cerebellar and the middle cerebral peduncle enhancement, as well as new right temporal white matter changes as well, and contrast enhancement. Again, this patient was given pulse steroids of IV methylprednisolone, and this time, instead of azathioprine, we shifted this patient to mycophenolate mofetil to 1500 mg per day.
Yes.
So,
So just a second, Shrita.
yes,
So as
sir.
you can see, he's a 16-year-old boy and he was put on a 100 milligram per day of azathioprine. As azathioprine is considered to be one of the maintenance immunotherapy, and he's had it for more than 6 months by then, and he relapsed. So obviously we were concerned, and as many of us would think of, we switched to what we at that point of time considered to be another good immunosuppressive agent for MOGAD, which was MMF. Over to Srijita.
Right, sir. So again, a quick recap about MMF. So the drop rate with MMF is pretty low. There's a modest reduction in the relapse rates, and Professor Lee and colleagues have shown that the relapse rates, when you compared the group with MMF versus the one without an MMF, there was a significant difference that was seen in both the groups. So with an MMF, there was a reduction in the relapse rate compared to those who did not receive an MMF. Moving on, now in August 2021, the patient has no symptoms at all. As you can see clearly in the MRI that is displayed, both the left cerebellar and the right temporal lesions have resolved. And now at this point of time, we have continued MMF 1500 mg per day for this patient. Moving on. Now coming back to October 2023, he develops, unfortunately, a bad left-sided ataxia once again. Now, when we repeated the MRI, we can see again flare hyperintense signal changes in the left cerebellum and the MCP. And this time, he again, as any relapse is treated, we gave him again a pulse IV methylprednisolone.
Srijita, just a second. So what used to happen is between the relapses we were closely following, and I was very I was following up this boy very closely, and I was examining him every time properly, and his ataxia used to improve completely.
Right.
and used to bounce back with with similar left side ataxia with similar left cerebellar symptoms. And this is the second time that I carefully looked at the contrast, and there was contrast enhancement. At one point, I thought whether there was some transient worsening, but the ataxia persisted for more than 2 days. And then we had to consider this as a new relapse. And we did what a neurologist would actually have to do. Srijita?
So we had to shift this patient to rituximab.
Go back.
And,
Just give the regimes.
right.
Yeah.
So we shifted this patient to rituximab, and it was given. The patient received 2 cycles, one each at an interval of 2 weeks, and then October 2023 and April 2024. And in between, he was again, like Sir said, absolutely responsive to the treatment and was stable enough. Now, coming back to September 2024, he has again relapsed. So we have again MRI images that were done outside when he came to the clinic, and we can see that there were again contrast enhancing lesions in the same location while he was given rituximab.
Just hold on. Don't go. Yeah. Okay, go ahead with this slide.
Yeah.
Go ahead with this slide, and don't don't push the button again. You should go ahead with this.
So basically, rituximab, it does not do so well compared to NMOSD and MS, like we see in these cases. So there were these lot of meta-analysis that were done, which said that rituximab, it reduces the relapses and the EDSS score in MOGAD, but to a lesser extent compared to NMOSD. And there was a reduction in the ARR as well. But if you compare that with NMOSD and MS, it is not so efficacious. So basically, what they've said is that these relapses, they don't appear to be linked to B cell repletion at all. So even in patients who had B cells that were low, these patients still had relapses. So which means that compared to an MS, it's probably not the case in these patients. So rituximab is definitely not something that
Strongest.
is very, very
Not the strongest.
not as strong
As we are using
in
as
NMOSD.
much in NMOSD or MS.
Right.
So this is the stage that we were in, and now really we became extremely concerned for the care of this patient. We had ran out of 3 important immunosuppressive therapies that literature recommends for MOGAD. And every time he's bouncing back, the durations were variable. Sometimes after say 7-8 months, sometimes after 1.5 years. But come whatever may, he has come back. And any suggestions as to how we should go about on this case, audience? An open invitation to all of you. What would you do in such situation where rituximab is not working? Yes. Shweta, has anybody raised hand? I can't see.
Right, IV gamma again,
Yes, sir.
gamma globulin.
Yeah, absolutely. I think sir is spot on.
I don't know about plasma also, but I think gamma could be a better choice in this case.
Absolutely. Spot on. So you're spot on this point. And that is exactly, yeah. But actually, Srijita, go ahead. We did something. This is what we did.
Oh. Was it wrong? Wow.
What we did, sir, was he was very well responsive to steroids. That was one good thing. We never had to use plasmapheresis. And then probably there was this thing that when the steroids used to, if at all we used to taper steroids slightly fast, then the symptoms would reappear. So we had learned that every time after the first event, we have been tapering steroids very slowly over 5-6 months. We have been very careful about that. And now, this time, we used tocilizumab. Srijita, go ahead.
So this patient was given tocilizumab. He received monthly doses, I mean 6 of these. And so even though they're not robust trials, but I mean, tocilizumab has been shown as a good maintenance immunotherapy. It's been associated with relapse freedom, resolution of eye pain, and ability to discontinue steroids in patients who have been given tocilizumab. And when the data was compiled from other case reports of patients of MOGAD who were treated with tocilizumab, they were seen that there were no clinical or radiographic relapses in 10 patients over a duration of almost 28 months. So that is the reason why we use this. But alas, the patient again had a relapse, even despite we gave tocilizumab. So again, the same symptom once more, and the MRI showing similar picture. And now we had to again give him pulse steroids. So I think Professor Shah gave us the answer already. So we started him on maintenance IVIG for this patient. And so basically, maintenance IVIG, even though upcoming, it's a promising maintenance therapy for MOGAD patients. There's been a multicentric retrospective trial done by Chen, where there has been a significant ARR in patients with MOGAD, and it has reduced from 1.4 to 0, especially when they were administered a dose of 1 gram per kg every 4 weeks. The same article, it compared all the steroid sparing immunosuppressive therapies, and they compared from MMF to azathioprine. They compared all the patients with, and they saw that the proportion of patients with relapse in case of MMF was about 70%. With rituximab, it was 61%. With azathioprine, it was 59%, and with IVIG was 20%. So you can see it is definitely emerging as a promising maintenance therapy for MOGAD patients.
So, in our patient, he's received just 1 gram per kilogram. He's around 50 kilos. So he's received one in March. We have not been able to give it monthly for financial constraints. He's received one in May and one in August. So instead of monthly, I have managed to infuse, say, every 2.5 months. As of now, he is very stable. He has not had any relapse. He's attending college, and the question comes in mind as to how long am I going to continue to infuse, and would it be possible for me to space the intervals between IVIG to cut the cost? Let us see. There isn't so much of literature about spacing them. There is some literature on medicines such as, natalizumab, where instead of giving every 28 days, they've then gone ahead to an extended interval schedule where they're giving it every 42 days or every 56 days. But MOGAD being a more recent disease, not so much in terms of, controlled trials with most of the therapies, more so with IVIG. I think the knowledge is not yet completely evolved. Let us see how my patient behaves over time. But this is how we at Dinanath decided to manage our patient, and as of now, for the past 6 months or so, I've managed to keep relapses at bay in my patient. Professor Shah and Professor Narasimhan, any comments on this patient?
Dr. Lakshmi, Dr. Ellen, are you here, dear? Dr. Lakshmi?
I think maybe sir is muted.
Well, I think he is busy with some emergency. Probably is not attending right now. Your points are well taken, and I absolutely agree that the knowledge is still evolving as far as this spectrum of disorders are concerned, and
Yes,
even
sir.
in many other antibody-related disorders. We
Yes.
have to know lot more things regarding spectrum of presentations, and there are certain missing diagnoses, missing antibodies in between the
Yes.
whole spectrum of NMS, which with time we'll get. And regarding treatment, also with newer immune check and other treatment, I think we will have more and more options. But currently, whatever you have summarized is absolutely precise and perfect. And as far as our center is concerned, we don't use azathioprine anymore. Somehow we find it a little weaker drug, and
Yes.
rather than wasting time, we insist on at least MMF.
Yes.
The cost is a big problem, right
Yes.
from the diagnosis to treatment in all NMO MOG, particularly MOGAD
Yes.
disorder. And not many people can really afford intermittent immunoglobulin therapy. But I like your idea of reducing, rather than reducing the dose, you are increasing the time period between the
Yes.
infusions. And
Yes.
we don't have any marker to decide how, I mean, but I think if it has worked, it is a point well taken. We can also try in our some patients. And generally, both your parts, dilemma of diagnosis and dilemma of treatment, are our day-to-day problems. You have addressed them very well. And I think we all need a large round of applause for what you present. I know you have many cases. The way you were talking there in the conference, we are really very surprised that you get a large pool of eating disorder and many other, but you have maintained a very nice record. So thank
Yes.
you, Dr. So Lakshmi is here again. Dr.
Yeah,
Lakshmi,
Lakshmi is in.
please come in.
I just want to make one point before Sir speaks. So again, I would reiterate this point that as it stands, sir, in India, we have now heavy reliance on rituximab in multiple sclerosis and NMOSD. However, with this case and a few more cases, situation is not similar with MOGAD. There are some MOGAD patients who may not respond as well to rituximab, and we have to think of alternative therapies, as you also mentioned. And this is one important point that I would like to share with my audience, that one hit doesn't fit all. So we have to look at each inflammatory disorder by its own way and treat accordingly. That's what I wanted to say. Sir?
Sir, there are a couple
Yes,
of
Dr.
questions in the chat box. What is your experience on cyclophosphamide and refractory MOGAD? Srinivas P.S. Naga.
Cyclophosphamide.
Yes. In refractory MOGAD.
Dr. Srinivas, somehow I have not used so much of cyclophosphamide in any of the CNS inflammatory disorders, which includes both NMOSD as well as MOG, honestly. My use of cyclophosphamide is mainly for vasculitis and SLE. These are the ANCA and other vasculitis and SLE. I have to be honest, I have not used cyclophosphamide so much in MOGAD.
In addition, I have used it in inflammatory myopathies also. I have used.
And inflammatory myopathies, yes.
Yes.
Of course. But sir,
I have also not used it.
You used it in MOGAD?
No, I have not used. I have never done.
So I think there isn't much evidence in terms of cyclophosphamide for MOGAD, really. Not so much of this thing for MOGAD. As much as
Dinesh Saini has asked us titer of MOG as discussed in the previous question. What is the titer? MOG titer.
Mock titer.
Titer.
Yeah. For the first patient, the mock titer was very high. Once it came positive, it was very high. I don't remember, but yeah, it was a significantly elevated titer. There was no doubt about it.
Okay.
Good. Any questions? We can't see the questions, sir. Yeah.
Sir, for the past 2 days, my hearty thanks to you. Wonderful exposition of central demand eating disorder. The entire team. My hearty congratulations to Gagi and Srijita. Srijita was excellent, very confident, and she has a bright future. I saw yesterday also, today also, a way of presentation. Everything was excellent. May God bless you.
Thank you.
And Gagi also, she did excellent presentation and very good collection of references. And my request is I would like to have that one of those references. I'll write a mail to Shripad. I just need one of those references which I didn't get.
Yes,
Okay,
sir. I'll
Thank
send
you so
you
much,
all
sir.
the
I
references.
think, sir. Surisha sir, shall we wind up, sir?
Yeah, and with a note that please start writing up this case for our upcoming book that we are planning to publish in the month
All
of
the case
February.
we are releasing as a book, sir. All these 60
Yes, sir.
episodes we are releasing, and I request them to write it up also.
Fantastic.
With,
Fantastic.
thank you.
That is going to be a very good
Yes, sir.
good thing, sir.
Yes, sir.
Very
Thank you.
good.
Thank you. Over to Chadda. Over to Shweta.
Diksha?
Yes, sir. Yes, ma'am. So, as we bring Secrets of Neurology episode 62 to a close, on behalf of Intas Pharmaceuticals, let us thank our panelists from Deenanath Mangeshkar Hospital, Pune. Dr. Shripad Pujari, your summary and conclusion beautifully captured the essence of today's discussions. Dr. Gargi Pore and Srijita Sengupta, your case presentations were thoughtful, precise, and a true reflection of academic excellence. Our sincere gratitude also goes to our course directors, Dr. Sudhir Shah and Dr. R. Lakshmi Narasimhan, whose vision and commitment have made Secrets of Neurology a trusted platform for learning and collaboration among neurologists. And finally, to all our viewers, thank you for joining us today, for your continuous encouragement, and for being a part of this journey of knowledge sharing. Your participation keeps this series alive and meaningful. We look forward to welcoming you again in the next episode with a new case, new discussions, and new insights. Till then, stay curious, keep learning, and good night. Thank you so much.
Good night.
Thank you so much.
Good
Thank
night,
you, sir.
everybody.
Thank you,
Thank you,
Srimad sir.
Professor
Happy Diwali in
Thank you, sir.
advance,
Thank
and
you.
we meet. What is the
Happy
next
Diwali,
date?
sir.
Happy
Happy
Diwali,
Diwali,
sir.
everyone.
Happy Diwali, sir. Happy
Yeah.
Diwali.
So, what is the next date of our presentation? It will be a conference.
Sir, it will be on 25th October.
Yeah, it will be.